Surgery. Surgery is sometimes an option for treating small cell mesothelioma depending on how far the cancer has spread. The main type of surgery is called an extrapleural pneumonectomy, EPP. In this procedure, the lining around the lung, one whole lung, parts of the diaphragm, and often the pericardium, sac around the heart, are removed. Lymph nodes around the lungs and heart are also sampled to check for cancer cells. While EPP aims to remove all visible cancer, mesothelioma often returns after surgery because tiny cancer deposits are left behind or weren't visible beforehand. EPP is also a major operation with significant risks, so it's usually only considered for patients in otherwise excellent health whose cancer appears limited to one hemithorax. For those unable to tolerate EPP, a lesser surgery called pleurectomy, decortication may be used to remove part of the lung lining and lung surfaces instead. Radiation therapy. Radiation therapy, also called radiotherapy, uses high-energy rays or particles to kill cancer cells. For small cell mesothelioma, radiation therapy is usually given along with chemotherapy after surgery to try to kill any remaining cancer cells. It may also be used to treat mesothelioma that has recurred after initial therapy or for palliative purposes to help relieve symptoms like pain. For radiation therapy, the doctor may use one of the following types of treatment. External beam radiation therapy. This is the main type of radiation therapy used. In external beam radiation therapy, a large machine aims radiation specifically toward the cancer area from outside the body. Treatments are usually given 5 days a week for several weeks. Common side effects are fatigue and skin irritation. Intracavitary radiation therapy. For this approach, a portable unit is placed directly into the chest cavity temporarily and left in place for a period of time to deliver radiation therapy locally. It allows a high dose of radiation directly to the site while lessening exposure to surrounding healthy tissues. However, it carries risks of damaging nearby organs and tissues and infecting the chest cavity. Internal radiation therapy, brachytherapy. This involves placing radioactive material directly inside the body as seeds, wires, or catheters. For small cell mesothelioma, radioactive material may be temporarily placed inside the chest cavity. Brachytherapy allows a high dose of radiation to be given over a short period, but also risks damage to nearby organs and infection. Proton beam therapy. This highly focused type of external beam radiation uses beams of protons rather than X-rays to deliver radiation therapy. Protons can potentially cause less damage to nearby healthy tissues compared to X-rays. Proton beam therapy for mesothelioma is still considered experimental. Chemotherapy. Chemotherapy uses anti-cancer drugs injected into a vein or muscle or taken orally to kill cancer cells. For small cell mesothelioma, chemotherapy is usually part of initial treatment along with radiation therapy after surgery to try to kill any remaining cancer cells. It may also be used for those who can't have or who have recurrent disease after surgery. Platinum-based doublet or triplet chemotherapy combinations are most commonly used, such as cisplatin plus pemetrexed or carboplatin plus pemetrexed. Common side effects depend on which drugs are used but can include fatigue, nausea, vomiting, low blood cell counts, mouth sores, hair loss, neuropathy, and hand-foot syndrome. Dose reductions or treatment delays may help manage side effects. Maintenance pemetrexed may also be given after initial treatment. Current research is also studying newer targeted therapies and immunotherapy drugs. Targeted therapy. Targeted therapy is a newer type of systemic therapy that targets specific vulnerabilities within cancer cells. For mesothelioma, targeted therapies such as anti-angiogenesis drugs and DGFR inhibitors are being researched but are not yet standard treatment options. Some targeted drugs that have been or are being studied include bevacizumab, Avastin, cetuximab, Erbitux, erlotinib, Tarsva, and nintedanib, Vargatef. Side effects generally depend on the specific drug but can include high blood pressure, bleeding, clotting problems, and diarrhea. More research is still needed before targeted therapy is implemented widely in routine clinical practice for small cell mesothelioma. Clinical trials. If standard treatment options have not worked or are no longer being effective, enrolling in a clinical trial of a new therapy may benefit some patients. There are active clinical trials looking at novel combinations of chemotherapy, targeted therapy, immunotherapy, and other novel agents. Trials are also studying new uses of existing drugs, surgical approaches, radiation therapy techniques, and other therapies. Participation in clinical trials helps advance the development of new and better mesothelioma treatments and gives some patients early access to new options before they become widely available. Potential benefits and risks of the trial must be weighed carefully. Supportive care. Regardless of the treatment plan, supportive care aims to prevent or relieve complications and side effects of the disease or its treatment. This may include pain management, oxygen therapy, nutrition, hydration support, blood transfusions, treating infections, treating dyspnea, shortness of breath, as well as symptom control from bulky masses or persistent effusions. Managing physical and emotional side effects of treatment can go a long way in improving quality of life during treatment and survivorship. Palliative care is also critical to managing symptoms and making patients as comfortable as possible throughout the course of the disease. The main treatment options for small cell mesothelioma depending on stage and fitness for therapy may include surgery with curative intent, radiation therapy for local control, chemotherapy with or without targeted therapy for systemic treatment, clinical trials, and supportive, palliative care. The optimal treatment sequence is usually discussed in a multidisciplinary tumor board to recommend a personalized plan offering the best balance of longevity, quality of life, and tolerance for each individual patient. Continued monitoring and palliative care remains important regardless of the initial treatment course. While the outlook is bleak, a multimodality treatment approach remains the best strategy to maximize likelihood of response and symptom relief.